I would like to thank SAGES for the opportunity to present today. My name is Fadi Dadale. I'm a surgical oncologist and a clinical assistant professor of surgery. I work at the Edward Elmhurst Health System in the suburbs of Chicago. The topic or the title of my presentation is "To Whipple or Not to Whipple?" That is the question. I have nothing to disclose. First of all, I want to start by really recognizing the SAGES Facebook group. This truly has been a fantastic resource for me, especially as I operate in a non-academic center. And so the opportunity for me to present some of my cases and review some of the cases with really national and sometimes international experts has just been wonderful. So I want to recognize this group and thank everybody who was helpful in coordinating it and making it happen. So what does it mean to Whipple, or what does the phrase to Whipple mean? I just want to state from the outset that I did not choose this title. And admittedly, my first reaction was sort of like this. I was a little confused on how I should interpret that, but then I did some thinking and I thought initially perhaps I should discuss the indications of pancreatic duodenectomy and what constitutes resectable, borderline, or locally advanced disease anatomically. But then I sort of had an epiphany and I decided to revert back to the Facebook group. And I noted during previous discussions that a variety of rather strong opinions emerge whenever a case of resectable pancreatic ductal adenocarcinoma of the head of the pancreas is presented, as some people would advocate proceeding directly with resection, i.e. to Whipple, and some others would advocate to give neoadjuvant therapy or not to Whipple. So consider this case: a 62-year-old ECOG 0 female presents with painless jaundice. A CT shows pancreatic head mass, which appears resectable, and EUS confirms that, and FNA confirms pancreatic ductal adenocarcinoma, and there is no metastasis. Should one resect or should one consider neoadjuvant treatment? So let's talk a little bit about pancreatic cancer. Pancreatic cancer, as most of you, if not all of you know, is highly lethal. It is the fourth leading cause of cancer-related death in the United States, and the only potentially curative treatment has to include surgical resection. However, only 15 to 20% of patients are candidates for resection upfront upon diagnosis. And even with surgery, median survival is quite bad at 11 to 20 months. In 1935, Dr. Whipple, Parsons, and Mullins published their first report from the Columbia Presbyterian Hospital on 3 patients that they performed a complete duodenectomy en bloc with pancreatectomy. The first reported case died on postoperative day 2 at 30 hours from a bad leak. The second and third lived for 9 and 24 months respectively. And that was the first or among the first reports of a proof of concept as the complete excision of the duodenum and the head of the pancreas can be performed. With the advent of vitamin K and development of blood banks, the bleeding and perioperative care improved dramatically, and ultimately Whipple advocated for a one-stage procedure after noting difficult adhesions during the second operation. And in 1946, he published a summary of what he learned, and he talks about the importance of creating a pancreatico-enteric anastomosis to drain the pancreatic juices, and also included a choledochoenterostomy, in other words, not an anastomosis of the gallbladder, to avoid complications from cholangitis down the line. In 1963, he published his series, and now the procedure bears his name. It should be noted that other surgeons during that era um, uh, um, uh, contributed to the science in a similar way and performed similar resections. However, he really popularized this procedure. So what happened next? Not a lot. Pancreatic cancer remained lethal. And in a very important study that I cite to my patients um, from the Memorial Sloan Kettering Cancer Center, the authors looked at survival trends after pancreatectomy over a 3-decade time interval. It's a very interesting study. They uh, categorized the outcomes into short, intermediate, and long-term survival. Long-term survival in patients who survived over 1 year was also included to decrease the effects of perioperative mortality and patient selection, and truly define how we've been doing oncologically for resectable pancreatic cancer. What the authors found is that the 30-day mortality rates over the 3 decades went down from 4.9% in the 80s all the way down to 1.3% in the 2000s. The 1-year mortality rates also went down from 42% in the 80s to 24% in the 2000s. That reflected in a slight improvement in overall long-term survival, as you can see here in the graph. However, when 1-year survivors were excluded, what happened was the survival became almost the same between the 80s, 90s, and 2000s. And that was still true after stratifying by node negative or node positive disease. And I won't um, um, uh, dissect the data further than this, only to show that really the operation hasn't changed too much since the time of Whipple. As you can see, while the perioperative mortality and morbidity got better, we really never got better at treating the cancer itself. And again, the meaning of that is that we are better at preoperative care. We have not made too much progress from an oncological standpoint through surgery alone. And later on, other studies corroborated those principles. And so, how things evolved afterwards came in the form of really robust, well-designed randomized controlled trials. I'm going to touch upon a few of the most important ones that I think everybody should know about. First, SBAC1 randomized patients by chemotherapy, chemoradiotherapy, or chemoradiotherapy followed by chemotherapy. And it was an interesting design of that trial, but really the take-home message from it was that a significant survival was noted with adjuvant 5-FU alone compared to no chemotherapy, and that survival was in the order of about 5 months median. CONCO 001 came after that and included 368 patients who underwent either R0 or R1 resections and had acceptable CA19-9 levels. And those patients were assigned to gemcitabine for 6 months versus no treatment after surgery. They further were able to stratify by resection margins, which were positive in 17% of the time, as well as TNN status. And the authors noted significant improvements in overall survival with chemotherapy, i.e. gemcitabine in this case, at 21 versus 10% at 5 years, and this persisted on an updated report to 12.2% versus 7.7% at 10 years. Following that, SBAC3 came and it randomized even a larger sample, 1,088 subjects to 6 months of adjuvant gemcitabine versus fluorouracil and leucovorin. And here, median survival was about the same. However, patients on the FU/LV arm, or in the FU/LV arm, had more grade 3 to 4 treatment-related toxicity, favoring gemcitabine. SBAC4 followed, also included R0, R1 resected pancreatic cancer patients, and assigned them to 6 months of gemcitabine alone versus gemcitabine and capecitabine. And the majority of the patients in both arms underwent R1 resections, 60%, and I think that coincided with the changing definition of what constitutes a positive margin. And the majority of them also had positive lymph nodes, and 80%. Here, this trial showed that combination therapy was associated with significant survival benefit, with a median overall survival of 30 months versus about 28 months, and a 5-year overall survival of 28 versus 17% in favor of combination therapy. Again, finally, most recently in 2018, I think this is probably the strongest trial in resectable pancreatic cancer that we have thus far. Included 493 patients with pancreatic ductal cancer after R1 or R0 resections, who were assigned to 6 months of gemcitabine alone versus modified FOLFIRINOX. It should be noted that we don't have dual therapy of gemcitabine and capecitabine compared to FOLFIRINOX to date. I should note that. However, impressively, median overall survival was better with FOLFIRINOX at 54.4 months versus 35 months, thus establishing the quote-unquote best treatment strategy supported by randomized controlled trials thus far. So what makes sense would be that we should give a multimodal therapy for everybody, because the evidence is quite clear that surgery plus adjuvant therapy affords the best chance at long-term survival or cure. So why not resect first and give everybody adjuvant therapy? And that seems like a fantastic plan. Well, it's not easy to do that, as the data shows. In an important study by Mirko et al., the authors looked at linked databases of NCDB and NSQIP between 2006 and 2009, and included 2,047 patients with stage 1 to 3 that underwent resection for pancreatic ductal cancer. They were trying to look at the associations between complications and receipt of adjuvant chemotherapy or treatment delay, which was defined at over 70 days from surgery. They found that about 23.2% of those patients had at least one serious complication. On the right-hand side, you see the panel of complications were defined as serious in that study. That includes SSIs, UTIs, wound dehiscence, and other serious complications. And they noted that overall adjuvant chemotherapy receipt was about 57.7%, which is consistent with other NCDB studies, and that 61.8% of patients not experiencing any complication ended up receiving chemotherapy versus 43.6% in those who had at least one serious complication. And they also noted that with increase in the rate of serious complications, the likelihood of not being able to receive adjuvant therapy went up by around twofold, with an odds ratio of 2.2. And this graph really demonstrates the important findings from the study. As you can see, if one has no complication, the rate of receipt or omission of adjuvant chemotherapy is lowest, and it gradually goes up depending on the type of complication and the degree of complication. In an updated report using the SEER database by Altman et al., the study was published in 2019. They looked at patients with pancreatic ductal adenocarcinoma that were resected up front, and they included 2,440 patients. Of those, 65% received no adjuvant chemotherapy at all, 28% received incomplete therapy, and 7% completed chemotherapy. They found that an NCI designation and nodal metastases were factors predictive of receipt of chemotherapy. And they found also that comorbidities decrease the odds of completed chemotherapy. And as one would expect, the not receiving chemotherapy or the patients in the no chemotherapy group fared the worst as compared to those who completed some chemotherapy, and of course, those who completed all chemotherapy. Median survival was 14 months versus 17 versus 22, and that was, of course, statistically significant. And so it's not easy to always administer adjuvant chemotherapy, and therefore we might have an opportunity to improve on that um, problem. And so a strategy utilizing neoadjuvant therapy emerged and has been increasingly utilized. Now, of course, it is standard of care to administer neoadjuvant therapy in borderline disease and in disease that's considered locally advanced. And the rationale really is to improve patient selection and avoid unnecessary Whipples in patients at highest risk of progression. Another important putative advantage is to improve rates of margin negative resections, as shown by a number of retrospective and now prospective studies that I'll talk to you about, and to treat micrometastatic disease early on. There's a fourth advantage that is probably controversial when we talk about oncological advantages, but I think is important that I'm going to talk to you about a little bit later. An important study by Dr. Ferrone et al. From the MGH back in 2015, published in the Annals of Surgery. They reviewed patients who underwent resection for pancreatic ductal adenocarcinoma and included patients with locally advanced and borderline resectable disease who received neoadjuvant FOLFIRINOX, comparing them to 87 patients who did not receive any neoadjuvant therapy. They noted that FOLFIRINOX resulted in a significant decrease in tumor size. However, also noted that 19 still were classified as locally advanced and 9 as borderline, seeing as the CT scan doesn't necessarily always reflect what's really happening on a pathological level. However, importantly, despite the continued unresectability on CT scan, 92% ended up undergoing R0 resections. In addition, neoadjuvant FOLFIRINOX resulted in lower morbidity, and this is an important point, no postoperative pancreatic fistulas, and a significant decrease in lymph node positivity. Now, the authors do note that the planes were a little bit more adhered and difficult to dissect, leading to longer operative times and blood loss. Nevertheless, the outcomes overall, including readmission rates, were all in favor of neoadjuvant FOLFIRINOX. Really, the only randomized trial that has been completely published on the utility of neoadjuvant therapy or neoadjuvant treatment is the PREOPANC trial. And in that trial, 248 patients with resectable or borderline resectable disease were assigned to either undergo surgery upfront, followed by 6 months of adjuvant gemcitabine versus gemcitabine-based chemoradiotherapy, and pre-op gemcitabine followed by surgery and 4 months of gemcitabine. And they noted that the R0 resection rates were significantly higher in the neoadjuvant treatment group at 71 versus 40%. They also noted an improvement in disease-free survival and noted that local regional failure-free intervals improved with neoadjuvant treatment. That said, overall survival did not reach statistical significance despite lower rates of positive lymph nodes, perineal invasion, and venous invasion. So again, while this trial didn't show an overall survival advantage, it should be noted that a lot of the putative oncological advantages that we talk about when we discuss neoadjuvant therapy were really confirmed in this trial. There's, of course, emerging data on neoadjuvant treatment. The SWOG trial was recently presented in ASCO, where 102 patients with potentially resectable pancreatic cancer were assigned to either perioperative FOLFIRINOX 12 weeks before and after versus gemcitabine plus nab-paclitaxel. And in the prelim report, resectability rates were about the same at 73 and 70%. And more patients receiving gem-nab had a complete or major pathologic response at 42 versus 25%. 2-year overall survival, however, was not different with either regimen at 41.6% with FOLFIRINOX and around 48.8% with Gen-Nab. And I think, one take-home message from that trial is that a neoadjuvant treatment is A, feasible, B, probably not a bad idea, probably equivalent to some degree between FOLFIRINOX and Gem-Nab. However, we still need to find ways to best appropriately select the regimen that patients are going to respond to. In other words, we need to have better biomarkers so that we can best select a neoadjuvant or adjuvant treatment for pancreatic cancer after resection. Now, my bias, we've been working on several projects trying to determine the impact of neoadjuvant systemic therapy on pancreatic fistula rates, and this is a study that we published last year. I just want to go over it. We analyzed NSQIP target pancreatectomy database for patients who underwent curative intent pancreatectomies and then performed a propensity score matching to stratify patients by receipt of neoadjuvant therapy and looked at postoperative outcomes. My hypothesis was derived from Dr. Ferrone's original report and other similar reports that show pancreatic fistula rates to be lower in patients that receive neoadjuvant therapy. So we included around 6,800 patients and ended up including 2,000 in each arm of the matched cohorts. Neoadjuvant chemotherapy patients had significantly lower postoperative pancreatic fistula rates at 9% versus 14.5% after matching. Before matching, that number was, or the discrepancy was even higher in favor of neoadjuvant chemotherapy. The majority of those were grade A. However, overall, 30-day morbidity was lower with neoadjuvant chemotherapy at 40.4% versus 49.5%, and this was statistically significant. That said, mortality was not affected. This is the table that highlights the different variables that were impacted with neoadjuvant chemotherapy, or the different outcomes that were impacted with neoadjuvant chemotherapy, I should say favorably. Those were organ space, surgical site infections, pneumonias, sepsis, delayed gastric emptying, pancreatic fistula rates, major complications, and length of stay, as well as unplanned readmissions. From that data, we truly concluded that neoadjuvant chemotherapy is a safe approach, at least from a perioperative standpoint, and there is a potential advantage of lowering postoperative pancreatic fistula rates. One explanation of that, after really kind of delving into the data, was that the effect of chemotherapy in some patients is to change the texture of the gland to a harder gland and a more fibrotic gland in some histopathologic reports, which might decrease pancreatic fistula rates by impacting the fistula score. In another study, we reviewed the NCDB of patients undergoing resection for non-metastatic pancreatic ductal cancer between 2004 and 2016, and again used propensity score matching to account for treatment selection bias. And we found that after matching, neoadjuvant chemotherapy was associated with significantly lower rates of 30-day readmissions, going down by about 2%, and that remained after multivariable adjustment. We did not find any significant differences in length of stay, 30-day and 90-day mortality in patients receiving neoadjuvant chemotherapy versus the ones who do not. And stratified analyses by surgery type, in other words, Whipple's versus distal pancreatectomies, demonstrated consistent results. Again, those data, we believe, reaffirm the safety of a neoadjuvant chemotherapy approach, and therefore, I believe, add to our armamentarium of literature on that topic. Excuse me. So finally, in this case presentation, a 62-year-old female with an ECOG of 0 presents with painless jaundice and a resectable mass. What do we do? In my view, we almost always administer neoadjuvant chemotherapy, sometimes chemoradiation, depending on the extent of the tumor. And the answer of to Whipple or not to Whipple, I would say not to Whipple is likely the answer, although we would be waiting for additional studies to confirm that. I want to thank everybody for their time, and I'll be happy to take questions.